In 2019, health officials both at home and abroad shared a confident consensus. The United Kingdom was one of the best prepared countries in the world to face a pandemic. The first 4 reports from the UK COVID-19 inquiry now provide a detailed assessment of that baseline, examining the specific ways the nation's contingency structures were designed and tested. The initial findings, detailed in Module 1, reveal that the government spent years preparing for the wrong type of disaster, focusing almost entirely on an influenza outbreak rather than a high-impact respiratory pathogen like SARS. Because the planning was tailored for the wrong virus, the country's pandemic simulation exercises missed the reality of the response required. These tests never accounted for the need to isolate the population, mandate quarantines, or enact whole system lockdowns. Those same preparedness exercises also possessed a glaring blind spot regarding the people who would need the most help. Planners largely ignored the specific needs and risks facing the disabled, the elderly, and minority communities. This pre-pandemic hubris created structural vulnerabilities that left the population defenseless before the virus even arrived. When COVID-19 actually arrived in early 2020, those pre-existing flaws hampered the political response, which is the focus of the inquiry's second module. Government leaders delayed implementing protective restrictions, leaning on an untested theory of behavioral fatigue. They assumed that if they asked the public to stay home too early, people would stop complying when the peak finally hit. This chart tracks the daily new cases of COVID-19 across the 4 nations in early 2020. You can see the flat lines on the left side abruptly turning into steep, exponential upward spikes in March, showing the direct consequence of shifting so slowly from a strategy of containing the virus to merely delaying it. And that surge accelerated even faster because decision-makers failed to recognize how the virus actually spread. By incorrectly assuming the pathogen was only transmitted by people showing symptoms and ignoring the threat of airborne transmission, the outbreak expanded entirely unchecked. Compounding this lack of understanding was a flaw within the Scientific Advisory Group for Emergencies, or SAGE. Modelers, clinicians, and behavioral experts worked in strict silos, meaning political leaders received fragmented information rather than a single integrated view of the science. By delaying political action and fracturing scientific communication, the government allowed a fast-moving biological threat to overwhelm their ability to control it. The weight of those political decisions fell directly onto the healthcare system, a cascading failure examined in Module 3. The inquiry found that the National Health Service entered the pandemic in what it called a parlous state. Years of workforce shortages and aging hospital estates meant there was almost no spare capacity to handle an emergency. When the sudden surge of infected patients arrived, that fragile capacity broke. The system couldn't cope, leading to catastrophic operational breakdowns in the most basic levels of patient care. This operational collapse inflicted severe psychological harm on bereaved families. Because infection control measures forced strict isolation, thousands of patients were denied what the inquiry refers to as a good death, dying without their loved ones present. This document shows a quote from the testimony of Anna Louise Marsh-Reese. She told the inquiry, "When we left the hospital, we were given my dad's stuff in a Tesco carrier bag." She added that most members' loved ones did not have a good death. Mortality rates track the scale of the loss, but the testimony of grieving families reveals the depth of the harm, a lasting feeling, as the quote concludes, that nobody cared. The inquiry shifts its focus in Module 4 to the one clear success of the UK's response, the speed at which vaccines and drug treatments were developed and delivered. This success was driven by an innovation called urgent public health badging. Instead of allowing standard medical research to bottleneck in a chaotic pipeline, the system drastically increased the speed of specific clinical trials, fast-tracking them above all other bureaucratic delays. This streamlined research process allowed the UK to bypass the wasteful, disorganized trials happening in much of the rest of the world, identifying and delivering effective therapeutic drugs at speed. Yet, even in this success, a persistent flaw remained. The vaccination program struggled deeply to reach the very populations most at risk, seeing consistently lower uptake among disabled people, pregnant women, and ethnic minority groups. Without a pre-planned, targeted strategy to build trust or reduce vaccine hesitancy, these vulnerable groups remained exposed, even as effective medical interventions became widely available. The inquiry chair, Baroness Hallett, concludes her reports with a stark warning. The medical workforce endured extreme burnout and trauma, working under conditions that many will never tolerate again. Technical agility managed to temporarily compensate for deep political and structural failures. But unless the UK urgently rebuilds its emergency frameworks and supports its healthcare workers now, the entire system risks a total workforce collapse when the next pandemic inevitably strikes.